Welcome. My name is Ryan Belikoff. Today we are going to talk about backs. With over 20 years experience dealing with backs, last lecture I mentioned that ergonomics was the top three injuries in almost all sectors, which is very true. And of those ergonomics, backs is usually the number one injury for these workers. So a very important topic. Today we are going to keep it basic. I know some of you had anatomy recently, but some of you it's been many years. So hopefully, no matter what level you are, you find this refreshing. Then we'll go into a little bit of research of where we are with assessing backs. We will have multiple modules doing assessments of backs, but today is more of an introduction. So why is backs important? So we already mentioned, number one injury. If we look at the occurrence through the general population, it has usually up to 80%. So this percentage goes up and down, 60 to 80, but for the most part, what I've seen is a prevalence of 80% of people in the adult population at one time or other will have back pain. So I know many of you are young. I hope you never had back pain, but with those percentages, almost all of us will be part of that, right? So, other reasons why back injuries are important to highlight is they're costly, so they take a while to recover, and therefore the businesses that you'll work for will have missed work days, so which is, something as a safety professional you're responsible for tracking. You get people back to work. This is going to cause a decrease in productivity, and then losses with having to replace those workers. Since, backs usually take a while to recover, oftentimes you lose those employees and have to retrain someone else. So beyond occupational perspective, we got a clinical perspective. As a chiropractor as well, I've dealt with a lot of backs, and usually as a chiropractor, it's usually lower back pain that's chronic. And this is actually one of not optimal scenario for backs. For treatment with chronic, because it's really hard to get rid of chronic low back pain. Chiropractic, acupuncture, usually those are actually more designed for more acute, even though the general population, they wait and use these alternative methods last. So it's been going on for many years. And so even though, chiropractic works more optimally in acute phase, oftentimes these practitioners are dealing with it in chronic. And then I worked for a medical clinic for, at least 5 years. Of those, this is during the time like 2012, when there was a lot of focus on opiates, even though they're, it's still in the news. This was really where we were highlighting it, because so many deaths were happening. It rose all the way up to the number two reason for people dying for adults from 30 to 40 because of opiates. And one of that reasons is because we don't have good treatments for backs. Just to put it out there, we have pills that, even though there's tons of different treatments, really, medication is the, go-to, and opiates, we've found is addictive, and so not the optimal treatment for these people. So the other thing is, oftentimes when a person has back pain, they just say low back pain, they just classify them all in one. You'll see that there's going to be thousands of diagnoses that a person can have for backs. So this goes to the second thing that says treatment efforts are primarily guided by symptoms. So that is the other reason why they just immediately just go low back pain without investigating it further, because a lot of times the experts, the specialists, usually they go to a primary care, which is not specializing in low backs. They specialize usually in like hypertension, diabetes, those type of things. Even though when I worked for the medical clinic, 60 to 80%, just like those percents that were going to their primary care for low back pain. And so they had to deal with it no matter what. Um, all right. So some basic anatomy. We have all these movable joints, and in between each of those vertebrae for the bones there, we have a disc. So 23 discs. Interesting enough, it counts for 25% of your column's height. And what you'll find is these discs are mostly kind of a fluid gel substance that's providing cushion. And what happens is that new joints passively go in and out of there. But throughout the day, gravity kicks in and we lose a little bit of height every at the end of the day, and towards the morning we've gained that height back. Um, Same could be said for as you get older. So unfortunately, those discs don't, have that passive nutrition as well. So you lose some height as you age. So muscles, back is really layered. So over 100 muscles. We don't really take the credit for how many muscles there is. So we divide it up into 8 groups. For vertebrae, we have 24 vertebrae. We're going to go through each of those sections. And then there's lots of ligaments that are keeping that spine nice and stable. And then it houses the CNS. So what is the CNS? So that's the brain and spinal cord that comes in. The spinal cord is in that canal for that in between the vertebrae that the vertebrae are protecting. And from that spinal cord, we have 31 pairs of spinal nerves that come out of there. So it is a complex part of our anatomy. Those segments, so I mentioned the segments. So the three primary that we mostly talk about: cervical, which is that neck. So we have 7 of those. And then thoracic, we have 12 of those. Vertebrae, we have 5. Often people don't regard the sacral region, so there's different regions in the sacral region. So that's that tailbone, and the tip of that tailbone is the coccyx. So we have 5 regions of the spinal region, and each have different shapes. So that thoracic in the middle back is really made to turn well. So when we look at a close-up, it glides very well, whereas the lower back, lumbar region, the segments go close together and they allow a gap for you to bend forward or back. And then the cervical, actually, you think of it turning your neck. Yes, it is, but most of that turning happens at the very top 2 segments. 80% of the rotation of your neck happens with C1 and C2 and C0. So spinal nerves. So one thing I still remember, even though I've done multiple dissecting classes, I've had lots of anatomy. One thing I thought was cool is when they come and do those displays with them and looking at, they get really fine on these nervous systems. But we have a huge network, right, of spinal nerves. And so this middle one is showing those 31 pairs of spinal nerves coming out of the spinal cord here on each level. And then on the lower back, we have a kind of a big one here. So that is your sciatic nerve, and it branches down as it goes down the legs. Muscles, again, we mentioned a lot of muscles in the back. But in general, when we're speaking about it superficially, we're going to divide it up into 3 basic segments of a deep and superficial and oblique. So most of these muscles are responsible for posture, just keeping us upright. Um, but then we have powerful extensors. What are extensors? So flexors is, closing that gap. So, doing a bicep curl. There we go. But extension is going the other way. So our back is primarily extending us, keeping us upright. So very good stabilizer muscles. And then we usually rank this stabilization for primary, secondary, and tertiary. So let's go through that. The primary is that myotendon system. So it stables the muscles first. And so when you have an injury, they are usually the first things that are injured that give away. And so we know this with strains. So that is a tear in the muscle. The secondary system is those ligaments. So that is a sprain that are keeping them intact. And then we got our tertiary stabilizers. So that's the bone. So, that's usually more severe injury. And so the bone usually breaks last of those orders. So the primary, secondary, and tertiary. So within the back, we have all these layers. We have nerves, muscles, tendons, fascia. Oh, I didn't go over fascia. Fascia is pretty much the wrapping around the muscles. There's a good book that's, kind of older now, um, called Muscle Myofascial Trains. And it shows how the wrapping around the muscle actually crisscrosses in the back. Um, and that could be really important because a lot of times, even though we have maybe pain on the right side, we'll feel on the left side. And it's very interconnected. And same goes with those nerves. Even though, we might have pain here, the pain might actually feel at other place just because we have a long network of nerves. So oftentimes, if we have an injury to a spinal nerve root, which is right along that spine there, it will shoot down all the way to either the tips of the fingers or tips of the toes, just showing how those nerves are interconnected. So tendon is that connection of the muscle to the bone, right? Ligament is bone to bone. So this is more of a close-up, even though we're like, oh, that's kind of gross, right? That's the actual anatomy, and it's actually, even though we have our textbooks, right? We look at these where we could easily identify the blood vessels that are red coming out of these colored pictures. Usually, when we're actually looking at it in real life, it's not as distinct. So, if you look at this picture, you can identify those blood vessels versus the bone. And it's very layered and interconnected and meshed together. So, the reality when you're actually, a surgeon's actually doing surgery, so much more complicated that we don't really give it credit for because we've all as health professionals had anatomy and looking at these textbooks, but when you actually do more human dissecting, it gets a lot more complex. Okay, so for bones, let's look at this vertebrae a little bit. So each one, the spinal cord is here in the middle here, and it branches out with this spinal nerve root right here on each side. So that's the lump coming out of that nerve. And then they go out, right? Depending on the location, we have the disc cushioning between each vertebrae. And so the shape, we have different shapes of that spinal. So when we talk about the mid back, it's bent forward. So we call that kyphosis, whereas the other way for the lower back and the cervical region, we're going to call that lordosis, that curve that goes in or back out. So that helps identify and it influences that shape of each of those vertebrae. Okay, so lumbar vertebrae, again, it is those connections to each other are more straightforward. Up and down allows that forward bending or backward bending. So in the middle, we have the body of the vertebrae, um, different parts. We call this the ones that stick out like a wings, transverse process. And then what you can feel in the middle, that you feel those little lumps on the back, those are your spinous processes that stick out there. And then there's a lot of other segments as far as the connection of the vertebrae, but I won't go into spinal anatomy too much. So when we look at the planes, and so this could be very useful if you're doing MRI, for example, and you're not sure what kind of plane it is, trying to think of these. So that sagittal in the middle is the most common view we're going to look at for MRI, and I'll show an example of that one. But sagittal is cut down the middle there from top to bottom, whereas the transverse is going across the body. So posture, so ideally, when you're evaluating posture, so this is just one evaluation. So a lot of times people think of posture as just a picture, a snapshot of where they are up and down, but really it is the movement of the body. And so ideally, if you had good posture, your middle of the ear would line up with the middle of the shoulder, the middle of the hip, going down the middle of the knee, and then the middle of the ankle. So, if you were looking at that side angle, you should be able to draw a line. If you had that good posture, it would all line up. So, if you looked at my posture, not so much. And I've given many talks about posture and lots of things to influence posture. Remember, posture is more about that coordination of the body. So it's always fluid and it's changing. So if you were looking straight up, people can lean, especially if they have scoliosis. So scoliosis is where you got a deformation of that spine. And so a lot of times, not only will a person be bent forward, usually they'll be off to the side. Because that arthritis, how it's changing, is not symmetrical, and so oftentimes it would be off to the side. But also, when you're working with workers, oftentimes they have a dominant side. Most of you have a very dominant side that you really practice. So if you looked at it, one shoulder height's probably going to be taller than the other one. Easy as a chiropractor, most of the time I could just look at a person just briefly and kind of know what's going on with them just based on posture alone of how those muscles are reacting. Okay, some lower back motion. So bending forward, we call that flexion. Bending back, like our arch, is that extension. Going off to the side. So when you ask someone to do this, if you were evaluating, you would just say, run your arm down your leg. And so they get a lateral bend, which we call lateral flexion, and then turning. So going across, that would be, a right rotation turn. And the same with the neck. So all of those are rotation. Again, the lower back has thousands of conditions. Oftentimes we just say low back pain, which is very mild. One of the things I want to highlight on this is, oftentimes we are thinking about musculoskeletal, meaning that there's an injury from like bending too much, just overdoing it, right? But just as important as there's non-mechanical back pains, and usually you don't have to deal with this. Cancers cause usually from wherever they are, the second place they always attack is the back, which is really complicated because oftentimes they'll just present with back pain. And that's where you have to go into a diagnosis phase. All right, do they appear ill? Is there warmth to it? Labs would be key to this. Um, Most of the time, it's not cancer or anything like that. However, you always have to have that in the back of your head, especially as a clinical provider. You as a safety, that's medicine, so not really your realm. But I want you to think, even though you're thinking of biomechanical, there's a lot of other things that could cause back pain. So then we got stenosis. That is the narrowing of the canal. Radiculopathy, that is when you have pressure on that nerve causing that shooting pain. Ankylosing spondylitis, that is where you have a genetic disorder causing arthritis. And so you can have multiple things. You can have AS, with this ankylosing spondylitis, with a mechanical back pain. And so you can have multiple conditions, and most of the time people do. So working at that medical clinic, I would say 90% of them had 10 diagnoses. So lots of interconnection with these. Oftentimes with back pain, people will say, I ruptured a disc, which is very painful, and I don't want to discredit anybody's low back pain. But here's the stats. So rarely is that the case. Only about 10% of the time did you actually rupture your disc. Most of the time it's biomechanical. If it's disc related, usually it's a disc bulge where it hasn't broken through. So when we say rupture, we're saying those fibers around the disc, and there's annual fibers, there's 3 of them that crisscross, has ruptured, and that gel is pushing on the nerve usually. So the body attacks that gel as foreign, causes more inflammation, it causes this vicious cycle. So a ruptured disc is very painful. Not saying a bulging disc isn't painful. So when it bulges, it can put pressure on that nerve, but it's not ruptured. So this is a sagittal view on the right side here of for MRI, and we're usually what we're looking at. So we got the disc in between those vertebrae. If it goes in so much, we know that it has ruptured. So all of these are probably just bulges because it's not hitting that spinal cord. This isn't the best view, but this is an example of how we're taking an MRI and diagnosing it. It's not as precise as we would like it to be, really. And the other complication is general population does have bulges just naturally throughout their course of lifetime. So it gets hard to diagnose. Was this injury causing a bulge, or did that person already have a bulge? Chances are they probably already had a bulge, but this work injury just caused it to get worse. So that's therefore workers' comp gets really complicated. Risk factors, lots of risk factors. So we think of non-occupational, so you can't really control that. Yes, as we age, like I just mentioned, you're probably naturally going to get disc bulges. Most of us get arthritis just from this repetition type of activities. Certain conditions with gender, some with conditions like AS, ankylosing spondylitis, more common with males, but certain conditions like RA, rheumatoid arthritis, way more common in females. So gender can play a role on your diagnosing of back pain. Obesity definitely complicates it. It's going to put more pressure on those discs, right? So this is just kind of physics. Pregnancy, unfortunately, I think most pregnancies do have low back pain, just because you're growing another being all that way in the front, causing that lumbar spine to curve even more inward, tilting those hips back. We'll want to talk a little bit about some research that's been done about that coordination. So it's very common for pregnancy. And then physical fitness. So motion is life, is a saying that one of my instructors way back in the day always said, and very true. So I can remember um, a female that was 25, and she played softball for yeah, a semi-professional league, but she had really bad scoliosis. So we're talking to the point where she should have surgery. So it was at 28 degrees, so it was quite a bit. But most of the time, I have people with, 12 degrees or less, and they could be in more pain, less functional, just because they were not active. So the body is meant to move. Occupational, so this is more of your realm. And, I want to highlight, even though psychosocial could be in the non-occupational phase, so very important. One of the things they really focused on, uh, because, I worked in this medical clinic, back was their primary condition throughout all of the US, and so the insurance wanted to focus on backs. And one of the things they focused on is psychosocial, and they found lots of benefit on looking at giving people behavior health therapy. But in the workplace, you gotta look at job satisfaction. Do they have enough supports? Um, how do they feel their boss listens to them? All of those psychosocial factors that we kind of take for granted are very important. And then, of course, the easier evaluations is the physical, right? We can actually measure how much weight a person is lifting. As you will see, NIOSH will say, 51 pounds to start out with, and no more than that. And then it should be reduced based on certain movements. Most of us lift more than 51 pounds, but it just goes to show Nash had a good research showing that, our bodies are made to lift no more than that. And part of that, what you don't think about, is not only are you lifting whatever object, you're also lifting parts of your body. So I'm, not a small guy, but if I'm lifting half of my body, it's like over 100 pounds, then add whatever I'm lifting. So we're already over. So that 51 pounds is just with the object. And this sounds conservative, but if you take all of those factors, not very conservative, really. So vibration, with the military, I can still remember helping lots of pilots that were helicopter pilots because they're exposed to lots of vibration, and they had a lot of back pain because of it. But lots of vibration, we take it for granted. But before we, perfected the engineering part, people would have back pain because of vibration all the time. And, it started with, tractors before we had cars, and it would give an abnormal amount of vibration. So we have made vast improvements with vibration, reducing it, but it's definitely something that complicates it. Static postures, so they say the new sitting is like the new cigarette. Sitting is like the new cigarette, meaning that it's really bad for you. And yet we all sit, a lot of us for our job set. So as a professor, I'm on the computer a lot, so I sit a lot. But even as a chiropractor, when I was treating, at least half my day was done charting and sitting again. So, and even that was a, pretty motion. So, something to think about. And then awkward posture. So we're really going to go into this, emphasize awkward postures, because that's something you can usually prevent with a tool. So, but usually workers will like just get the job done, but they're not helping themselves, and therefore they're not helping the company. So, something to definitely address. So, I mentioned there's lots of treatments. So this is a diagram with the American College of Physicians. of, how you can flow chart you can go about it. Again, the first thing you want to do is try to make sure it's not something that's a red flag, like cancer type thing. And then you can give NSAIDs and work it up. Ideally, now on this one is some of those alternative treatments like chiropractic, acupuncture. All of those are best done in the very beginning. And then, surgical should be one of those last resorts. We've got so much better at surgical, but I want you to remember how complex that back is. Very layered. When we're taking a knife, there is no going back. So, and then there's scar tissue to be involved with. We just think of, oh, they'll go in there with that ruptured disc, take that ruptured disc out. Usually what happens is, remember, that is a passive thing. It comes in and out. If it hasn't scarred all the way, it's going to push right back out because that fluid is going to gain back in there, putting pressure on that scar, immediately rupture. That's why they tell people to take it easy when they first, have that surgery, and a lot of people don't take it easy because of life. And we take it for granted how much pressure we're putting on that back. Not to mention, most of the time, when I was treating people and they had back surgery, they had at least 3 back surgeries. Oftentimes, unfortunately, other areas influence. So if you decrease that height to that disc, it affects the above and below the joints. So oftentimes they have problems with one of those joints, as well as usually they're addressing that one area where they had that surgery because it causes scar tissue, and then that scar could actually put pressure on it. So you could see, even though back surgery has good intentions, you should definitely, no matter what, put that as a last resort. There's lots of surgeries out there. One thing I haven't mentioned is injections. There's injections. We can try to reduce that inflammation by targeting it. But again, that body is designed to take those excess fluids and move them around. So it's designed to, take that injection fluids out from that area and clear it. So it just goes to show, even though there's lots of treatments, I want to emphasize that there's really no optimal treatments for the back, even though we have thousands of different treatments. It's just whatever can help. So we're going to talk a little bit about basic research. I would just divide this up into, we can divide it on the source of actually identifying it, how back pain happens, actually sensing it, the diagnosis. So I mentioned MRI, so that's usually a good way to diagnose, but remember, it gets really complicated, right? Because if people naturally, build into a disc bulge, how do you know that that disc is what's actually causing the pain, or is it something else? So, MRI sounds straightforward, but it's not really. But usually what really diagnoses is the combination. So orthopedic tests, so like for that disc, for example, we want to do a straight leg raise. We do that MRI. We take their history. So musculoskeletal is one where history is so important. History is, talking to the patient, tell them what's going on, what happened, how long is it happening. All of those can account for 80% of that diagnosis, which we often think, oh, they're going to do a blood test, they're going to do an MRI. But when it comes to musculoskeletal, history is key. And then the interpretation of that. So we have lots of assessments. So we're going to do assessments mostly in this class. The beginning of a few weeks is going to be basic overviews of all this, but assessments. So we're going to build into from assessments with worksheets. There's lots of work that has been done with these worksheets to assess whether it's the shoulder, the back, whatnot. But then we have increased our technology using the EMGs, ultrasound, all of this, and now that we can use in the workplace. So optimally, if we were trying to get how much pressure is happening in the back during certain movements, we can measure that, by actually, putting sensors in the back, especially that disc, to see the pressure that is occurring with how many newtons of force. However, that's very invasive. So, we have good research from 30 years ago when they did these kinds of research showing like when we're sitting, we put a lot more pressure on the back than when we're standing. And the worst pressure we could do is sitting with bent over. Bending over is not good. From those studies, we really know really accurately. But we have moved on from putting those sensors directly in the back because it's very invasive. So, it could be harmful for the subject. So, more of a gold standard is using these EMGs. So we can signal how much muscle activity is being performed while doing this. We can also do imaging or deformation body models so we could see how that spine changes with each of those motions. More real time, we have sensors, we can see the movement of the body, how the body is coordinating. So, from these EMGs, we can kind of infer the demand of that task, what kind of muscle forces are being initiated. And so now, we'll go through those models. We have ErgoMaster is one of them that we could take a snapshot and it can, based on the body's posture, their movements, estimate those forces. So lots of cool technology that we have for real time that we're, now getting into. Oh, and before I forget, my last research focused on quite a bit of posture stability. So a person would stand on this balance scale pretty much, and we naturally sway, and based on our activity levels, how fatigued we are, we sway even more. And so that is, ground reaction forces. It goes from the top of our body to our feet. So that would be another example of evaluation. One of the more recent models is looking at passive tissue contribution. So notice each one of these is a segment in the lumbar spine from L1 to S1. And so axial compression, which is not surprising as you go lower to that L5S1, which is the main segment most people have problems with. Yeah, that axial compression with flexion is increasing more than any other segment. So just one more validation. But this takes a step further, using that coordination of that passive movement. And notice that it's not a 1-to-1 ratio. So you would expect that L5S1 to have more flexion, but as you can see, it's in the middle of those. So looking at individual segments, how that passive tissue also contributes to the movement and the axial compression. So this is a more recent model we're trying to use with our exoskeletons here for research. So we're taking a weight they're lifting. So our exoskeletons has a spring in it that is supposedly to lift counterweight 60 pounds. So we have that external load. But we're using these different models to kind of calculate the forces based on the joint movement. And so here's an example. So we got two different motions. So oftentimes people don't know what a stoop is. So that's when the back is straight and we're not bending it. So the back is straight while we're lifting an item. As you can see, not the most ideal way to lift, right? Squat, we say bend with our knees. So that trying to keep that object as close to the body as possible. So this is example looking at the two different types of lift and how it can be influenced in these models. Okay, so as you can see, we're evaluating a stoop versus a squat and the amount of forces with the muscles that is being exerted. So naturally with that stoop, they are further away from their central line of gravity. And so, for that active movement, this is that first graph here. Yes, you're seeing more active muscles further away, more movement with the stoop versus the squat. Interestingly enough, the passive muscle contribution is quite a bit more with that stoop than than the squat. And then this is the net of the two. So it just goes to show, how important keeping that object to the closer to the body is. And this is just one more research project, helping validate that. So compression forces, again, we would expect that the compression with the stoop is more with it further away from the center of the body. So we definitely see that compression forces. And so as you can see, it gets to almost 5,000 newtons, which is way more than we want optimally. That's, definitely in the danger zone. That shear force, so the compression is, directly, our discs are made for that compression. But the shear forces is going to, they're the two vertebrae stacked on each other, kind of a shearing force. That's why we call it shear force. So the spine can take a lot less. Again, even with shearing, that stoop is more than that squat, just to give you some actual measurements here. So we're at 15, a little above 1500 for that stoop shear force, which is quite a bit. So that kind of concludes our lecture for today. Please reach out to me if you have any questions. Thank you for your attention.